Welcome to Chapter 15. And now we go into genetic testing for the risk of cancer. And this may not only just have analytical validity, but a little bit more clinical validity and utility. We're still calculating a risk, but there are some things that we can do about it if we know that certain mutations are present. And so you're seeing pictures here of breast cancer, and then the actual histological picture of the breast cancer here on the right. And that, of course, is going to be our example for this chapter as well as for our last case study. And the reason I'm using breast cancer again for the case study as opposed to another cancer, well, number one, we know more about breast cancer now than even colon cancer, but number two, I want to review some of the earlier basic information about DNA and DNA replication and stuff before you have your final exam next week. So let's move on. So we'll start with getting to know Jean. This is Elaine's mother. Jean is going in for a biopsy on a suspicious mass found in her breast. So her husband calls Elaine, their daughter, to let her know for it. Jean herself is 55 years old and has had fibrocystic disease. Even so, she hasn't gone in to have biopsies as much as she probably should. So Elaine tells her husband, Jim, the daughter, Elaine, that she's going to go home and stay with her mother while the biopsy is being done, and they wait for the results. Of course, I think most of you are aware that breast cancer affects about 1 in 8 women in the United States. When I first started learning about this when I was an undergrad, admittedly that was some time ago, the risk used to be 1 in 9, and now it's 1 in 8. Therefore, routine mammograms are encouraged, particularly at the age of 40 and thereon. And of course, there's controversy going on right now about whether it should be yearly or every 3 years. We'll review some basic facts about breast cancer. It is derived from an epithelial cell, so it is classified as a carcinoma. The most common form is what we call an invasive ductal carcinoma. Of course, it's staged based on the size of the tumor, whether it has spread to the lymph node, and then whether it has metastasized to distant tissues. Therapy then will be based on whether a woman is pre- or postmenopausal, whether they are BRCA1 or 2 positive, and then they will do genetic studies on the tumor cells. Okay, and they will look for things like the estrogen receptor and then overexpression of HER2/neu is how I always refer to it, but HER2/neu is actually another growth factor receptor, but it also has this tyrosine kinase activity, and that just means it adds phosphates to tyrosine, which is an amino acid on other proteins, and basically what it's doing is initiating signal transduction and then usually cell replication. So the cells start to grow uncontrollably. It's also been known for some time that first-degree relatives of an individual with breast cancer then has a 2 to 3-fold higher risk of developing the disease as well. As a result of this, researchers began to look for a particular gene that could increase one's risk for developing breast cancer, and that's when they found the BRCA1 and BRCA2 mutations. Then we found that these were tumor suppressor genes. In other words, they typically halt progression of a cell through the cell cycle so it doesn't divide and increase in number. And additionally, also has a role in DNA repair mechanisms. Well, for things like the BRCA1 and other genes, there are clinics that can offer this genetic testing, but also the counseling. That's very important as well. If someone is of Ashkenazi Jewish descent, they also have an increased risk for this, so testing, as we learned in a previous chapter, can be important for this. And there are actually computer programs that can determine one's probability of having a BRCA mutation based on family background and things like that. So you can put that in there. But genetic counseling is really critical to any kind of risk assessment when you're dealing with cancer. I know on a personal basis, at one point in my life, that it was thought that I had lung cancer. Turned out to be a very rare benign tumor that I had in the lung, but very rare, so most people assumed it was lung cancer. When you get that diagnosis, I can tell you from personal experience just how scary it is, and all the things that go through you. So emotionally, you need the support. Ethically and socially, you can need this additional problems because you may have problems with life insurance, jobs, etc., and then legal issues as well. So there's a lot to deal with if you're given a positive result on a mutation for a familial cancer. Now this is just, again, showing you what we're talking about. You can see a normal mammogram over here. You can see a benign cyst. Notice how well defined it is. Usually they're encapsulated, this sort of thing. But cancer is more diffuse like this, and it's because they have a tendency to be more invasive and they don't retain any kind of well-defined border. So this is very classic of what you would see. So, Jean has her biopsy, and she does indeed have an invasive ductal carcinoma of the breast. The physician, of course, recommends that the mass be excised, and a sentinel lymph node biopsy should be performed. He suggests a modified radical mastectomy. However, no data suggests it improves the outcome, so she, of course, like most people, agrees to the lumpectomy, as we've always referred to it since it started. And so this is just to give you an idea of what the normal breast tissue looks like. And this, of course, we saw on the first page here of this PowerPoint, looks what invasive ductal carcinoma. And this is what I mean about it loses its normal structure. You have really no idea when you look at this, the one on the right, in terms of what kind of tissue it is. And that's classic for an invasive carcinoma. Well, after they do the staging, they find that Jean is in stage 2 breast cancer. The lymph node was positive, but the tumor is small, less than 5 centimeters. So there is an 80% or better 5-year survival rate, which is good. And they advise Jean to undergo radiation following the surgery. Then, of course, what they're going to do is collect from the biopsy, and once they remove the tumor, they can then take some of the cells and look at the tumor's gene signature. And this is what they do nowadays, and this is one of the things that genetic testing has really helped us with, assess a tumor's aggressiveness and what kind of drugs that would work best. Now, with Jean, her tumor was estrogen receptor negative and was also negative for the amplification of the gene HER2 neu. Well, the estrogen receptor negative means that they can't use tamoxifen. Tamoxifen will bind to the receptor, estrogen receptor, and inhibit estrogen from binding, so it slows the growth rate of the tumor. So they can't use that, but it is good not to have an amplification of the HER2 neu. So since she can't take tamoxifen, they recommend the chemotherapy. And this is just showing you, you have a similar picture in your textbook of how they would go about testing for the HER2 neu amplification. And as you can see here, the normal cell has very little of the gene expressed here, whereas here with the tumor cell, when it's overexpressed, you can see how much more is present. And of course, that's going to typically find even really small amounts of growth factor to none at all and still keep the cell cycling. And that, of course, helps promote the formation of a tumor. And of course, this was used using fluorescent in situ hybridization, which we talked about a number of times now. So chances are I may ask about this on the final exam. So I'm giving you a few clues. All right. So we've talked a lot about Jean. What about her daughter? This is Elaine's concern. 6 months later, Jean is doing okay. Managed to put up with the chemo pretty well, and things are looking good. But Elaine is getting kind of scared, and you can't blame her. She's very concerned about her chances of developing breast cancer. You hear so much about this on the news and everything. So Elaine's online research, which is what everybody does these days, reveals that she's got an increased risk just because she has the family history. But she's got more than just her mother. Elaine's aunt, her mother's sister, died of ovarian cancer at age 55. So that's suggestive of BRCA. And her grandmother's sisters died of breast cancer many years ago. So this clearly seems to be present in the family. So when Elaine tells this to her gynecologist, the gynecologist, I should say, refers her to a cancer geneticist. Well, before she gets in to see the geneticist, of course, they're going to want a pretty extensive family history, as much information as you can possibly get. So Elaine has to fill out quite an exhaustive form, and she's 24. She's married, has a healthy 2-year-old daughter. She also has an older brother and sister. Both are healthy, married, each with 2 kids. Elaine's mother, Jean, of course, has breast cancer. Jean's sister died of ovarian cancer. Jean's brother is alive, so this is Elaine's uncle. He's got hypertension, but otherwise he's fine. Jean's parents, would be Elaine's grandparents, are both dead. The mother died of an accident at age 48, and the father died of a heart attack. So that doesn't really give us any information about the breast cancer. However, the mother's sister died of breast cancer, but this was more than 40 years ago, so we don't have any records about that. And neither of Elaine's parents are Jewish, which means she isn't, so at least she doesn't have the increased risk because of the Jewish inheritance patterns. So, with part 6 and 7, the genetic counselor does advise Elaine to have the BRCA1 and 2 genes sequenced, not just for the common mutations, because since there is indication that this is present in her family, and since these are fairly large genes, there could be lots of different types of mutations. There have been those reported, so getting the whole thing sequenced is important. And as I've said, they're very large. A lot of mutations have been identified. In the U.S., it's Myriad Genetics that does all the BRCA1 and 2 testing. If one is not of Jewish descent, and the reason for that is because the Jewish descent will kind of ensures that you have the most common, 1 or 2 of the most common mutations. So if you don't have that, you may have some of the less common ones, and so they recommend the complete sequencing. And they would like as many people in the family to be sequenced as possible, but Elaine's mother, Jean, is very tired of all this, and she doesn't want to be tested. And you can't really blame her. She's just trying to get her life back to normal after all the others. So getting other people to answer questions and agree to be tested, this is part of the ethical problems that can occur with this. And then once they have that information, who should be privy to it, if you will, is another problem. So what's Elaine's test results and decision? Well, 2 weeks. She finds she does have a pathogenic mutation in BRCA1. Some mutations are inconclusive, but hers is not. So this gives her an 80% risk of breast cancer, 44% risk of ovarian cancer by age 70. There is no definitive treatment other than bilateral mastectomy, which can reduce the risk for breast cancer. And then after menopause, they recommend removing the ovaries and fallopian tubes to reduce the risk of ovarian cancer. So after talking about this with her husband and worrying about their daughter and whether their daughter will grow up with their mother, having a mother, Elaine agrees to undergo the radical mastectomy. This is a summary slide for chapter kind of 14 and 15. Our genes do determine how healthy or unhealthy we will be as we age. This is a truth, okay? Environmental factors will also come into play, but how we respond to things and don't respond are determined by the genes that we inherit. Sequencing the human genome has opened the door for us to see how genes can interact with each other to promote or prevent the development of some of the common multifactorial disease, but also how they interact with the environment to produce these common disorders. Typically later in life, it takes a while for them to develop. But there are still many, many questions to be answered, and we simply cannot predict who will or will not become ill, but we have a greater appreciation, I think, for the miracle that is life. So, after this, we will have our last unit, our final exam. I hope you're feeling a little more comfortable with the material as we've been going through these actual practical cases and then sometimes reviewing that early stuff from the beginning, so that by the time you finish this course next week, you will feel that you can at least advise people properly where to go should they have a serious increased risk of a disease or be a carrier, and be able to incorporate in this information into your practice. So I'll see you next week.